Dr. Hussain. Oh, let me just put that down there. So my job this morning is just to give you a very brief overview about genetic testing in the field of cardiovascular disease. I have no disclosures to report. And just before we start, wanted to get a gauge of the temperature in the room to ask you what kind of access to genetic testing and genetic services you have in your community. So that's the question, is do you have access to genetic testing in your community and in your practices? And the responses here would be yes, I have easy access to genetics clinic or genetic counselor. Option number 2, I have access to a genetics clinic, but it's difficult and it's slow. No, I do not have access, but I know who to call to gain access for my patients. Or fourth response is no, I do not have access to a genetics clinic and do not even know who to call. So if you want to think about that for a moment, you've got 15 seconds to answer that question.
And remember to press submit.
Yeah, thank you. Okay, so around the room it looks like, yes, there is access to genetics, but it's difficult and it's slow, which I think is not an uncommon response in this scenario. You'll notice here, though, that there are a number of people who don't actually have access and aren't sure who even to call. So I think that's something that really needs to be addressed overall moving forward as we become more bombarded with information, both in the popular media, medical literature about the value of genetics and genetic testing in the diagnosis and risk assessment of patients with cardiovascular disease. And I think it's a difficult field to navigate in some ways. And so what we're hoping to do is really speak a little bit to these questions when it comes to genetic testing. And this particular subject is sort of who are the right patients to consider genetic services or genetic testing for, why you might want to do that kind of testing for these patients, what test is the correct test to offer, or what is the correct path to go in terms of genetics, and how do I access those services for my patients? So when we're talking about genetics and heart disease, I think it's important to sort of break this into a couple of broad categories. The first one would be those kind of rare single gene disorders. These are the conditions, the cardiomyopathies and the arrhythmia syndromes that really are what you hear about in terms of those dramatic events often. So those young athletes who die suddenly on soccer pitches, these are the conditions that you might see a couple of in your practice, probably not going to be struck with every single day, as opposed to the second category, which are the much more common things that we would see in a general cardiology practice, including things like atrial fibrillation, coronary artery disease, that affect quite a higher prevalence of individuals in the population. So just to break those down a little bit further, we talk about rare monogenic disorders. I think the key word here is rare. The most common would be hypertrophic cardiomyopathy with a prevalence of about 1 in 500 individuals, but some of the more uncommon arrhythmia syndromes can be as rare as 1 in 10,000. When it comes to the genetics of these conditions, they are all, I want you to think back now to sort of genetics 101. These are autosomal dominant conditions whereby a person who carries an alteration or a mutation in one copy of a disease-associated gene is a person that is at risk to develop that condition. I say at risk because all of these conditions display what we call variable penetrance and expressivity, meaning that not every person who carries the gene mutation will ultimately develop the condition, and those that do can be affected quite differently. So they can be the onset can be at different ages. We see from young age to early to older ages in terms of onset, and with different degrees of severity. So when you have a patient or a person that is affected with one of these conditions because of the autosomal dominant inheritance, each of their children, siblings, and parents are at a 50% risk to also carry that same alteration or mutation that puts them at increased risk. And this here is just to highlight the fact that these genes or these conditions generally are associated with well-defined genes for which there is good evidence for a disease gene association. So good evidence to show that the gene in question actually does put that person at significant increased risk for that particular condition. And so in the population, you're going to see rarely people are affected with these. So an individual in blue, for example, in this particular slide is affected. There's not very many of them in the general population overall, and they're likely to carry these causative disease gene variants. And while you can see people that carry one of those disease-causing mutations that doesn't have the condition, that doesn't happen quite as often. So we see relatively high risk for gene carriers in this particular population. So with the second group that we're going to talk about today, which are the more common multifactorial conditions, genetics and genes are one of the many risk factors that play a role. We certainly have multiple genes that can come into play here, environmental factors, modifications to genes that occur over time. And these kinds of conditions are associated, the genes associated with these particular conditions are associated with either increased or decreased risk to develop the condition, but of smaller magnitudes. So what you would see here in the population is you see the affected individuals are much more prevalent. We see all the blue individuals on this slide. And so again, things you might see commonly in your practice. The associated gene variant in question is carried by some of those people, but there are a lot of affected individuals in the population who don't carry that gene variant. And vice versa, you see people that aren't affected, many more people that aren't affected that might also carry that gene variant. So it's just a different thought process when it comes to the genetics associated with these two different groups of conditions. So very briefly, I think one of the questions that we hear a lot is genetic testing, isn't it just a blood test? What do we really have to think about here? And while, yes, it technically is just a blood test, or even in some cases a saliva test, which we're seeing a lot more of, there are some things to think about that are different between these two groups. So monogenic disorders, this is genetic testing that is typically clinically available. However, it's important to be aware there are discrepancies regarding availability across the country. The interpretation of these results are highly dependent on the accurate phenotype and diagnosis of the person in front of you. And that's key, and Josh and Dr. Mital will talk about that as well, and that there is a significantly increased risk associated with the presence of a disease-associated gene variant. Whereas with multifactorial conditions, these are really tests that are not particularly clinically available right now. And that's an area that Dr. Hussein and Eriska will talk about. These are tests that come in the form of these more direct-to-consumer things we hear about, like 23andMe. And the associated risks are generally related to odds ratios based on what evidence is available about disease gene association, but also to be cautious that the evidence associating some of those genes with these conditions is not always that strong. So there are certainly limitations to what this kind of information can provide you. So moving forward, we're going to highlight some of these points for you. We're going to start, I'm going to introduce my colleagues, Dr. Seema Mital and Mr. Josh Silver, sorry Josh, to come and talk about genetic testing for hypertrophic cardiomyopathy.
Thank you, Melanie, and good morning, everyone. So we will talk about genetic testing for hypertrophic cardiomyopathy, but just to make the case that the principles or guidelines that will be discussed in relationship to cardiomyopathy can apply to most monogenic disorders. Myself and Josh have no disclosures. So let's start out with a case that one might commonly see. So this is a 16-year-old boy who had a syncopal episode during a basketball game. The resting ECG showed voltage criteria for LV hypertrophy. The echo showed basal septal hypertrophy to the tune of 22 millimeters in diameter. On physical exam, there were no obvious systemic abnormalities. However, when we did a deeper dive into the family history, it became obvious that there was a family history of unexplained sudden cardiac death at a relatively young age on the paternal side. So the paternal uncle and the paternal grandfather had episodes of sudden unexplained death. So we went on to do a workup to rule out secondary causes of LV hypertrophy, which includes ruling out hypertension, aortic valve abnormalities, as well as athlete's heart. In addition, workup was done, which included a neurological exam to rule out neuromuscular disorders that can be associated with cardiomyopathy, malformation syndromes. Blood work was done to rule out inborn errors of metabolism, and cardiac MRI to rule out infiltrative disorders like amyloidosis. With the negative workup, we were left with the diagnosis of primary or isolated hypertrophic cardiomyopathy, which, as Melanie explained, is an autosomal dominant condition. It is highly polygenic. In other words, overall, there are upwards of 100 genes involved in different types of cardiomyopathy, although a smaller number cause hypertrophic cardiomyopathy. And importantly, there is significant inter- and intrafamilial variability in the age of onset, severity, and progression of disease. and there can be incomplete or reduced penetrance in any given family member. So I'd like to move forward with an audience response question. And the question here is, what would be the next diagnostic steps in the workup of this 16-year-old boy with hypertrophic cardiomyopathy? And what I would want you to do is choose the incorrect statement. So the first question is, screen all first-degree relatives of the 16-year-old with an echo and ECG. Second, screen all first-degree relatives of the other family members who had sudden cardiac death with echo ECG. Refer the patient to genetic services for genetic counseling and genetic testing. And number 4, offer genetic testing to all family members. So please go ahead and vote.
Don't forget to hit submit.
That is very interesting results. This is nice to know that the audience actually has identified the incorrect statement. So it's absolutely true. Whenever you see a proband or index case with cardiomyopathy, we definitely want to screen all the first-degree relatives with echo ECGs, and also the relatives of other members in the family who've had sudden cardiac events. Important to refer for genetic testing, but really only the proband in this case, because the yield in genetic testing is going to be highest in a phenotype-positive member, and unaffected members should not be used as for screening for genetic test results unless the proband turns out to have a positive result. So I'm going to move forward and have Josh take over how to go about genetic testing.
Thank you. So over the last several years, there have been a number of different guidelines published on the utility of genetic testing for patients with cardiomyopathies and primary arrhythmias. And we'd like to highlight one particular position statement by the Canadian Cardiovascular Society and Canadian Heart Rhythm Society. And the key points from this article list that, first of all, diagnostic evaluation for suspected hereditary cardiomyopathy should be performed by a physician expert who's well-versed in both the clinical and genetic aspects of cardiomyopathy. Decisions regarding the utility of genetic testing should be made in collaboration with a genetic counselor. Prior to pursuing genetic testing, patients should receive comprehensive pre-test genetic counseling, which would include a discussion of the psychological, social, and ethical implications of genetic testing. And genetic testing should not be ordered on asymptomatic family members in the absence of a parallel clinical assessment with a physician expert. The role of the cardiologist in the genetic diagnosis of cardiomyopathy includes, of course, first of all, making a clinical diagnosis of cardiomyopathy. As Dr. Mital mentioned, performing a baseline workup to exclude secondary causes of cardiomyopathy, and also referring to genetic services for pretest counseling. And that might be to a traditional medical genetics clinic or to a specialized genetic counselor who is embedded within a cardiology clinic. The traditional home of genetic counselors has been the medical genetics clinic, but in recent years, genetic counselors have become increasingly more specialized to certain organ systems, and you now, especially in tertiary care centers, tend to or more often find genetic counselors embedded within cardiology clinics. There's still only a few within Canada, but it does exist. And the role of the genetic counselor includes performing genetic risk assessment and offering pretest counseling to the patient and the family, interpreting genetic test results and returning those results to the patient, facilitating communication of genetic risk between the patient and their family members, and of course offering familial cascade testing, which is offering genetic testing for pathogenic gene mutations to unaffected family members. And in some cases, genetic counselors may be involved in a research capacity as well. As you can see here, I've listed the cities in Canada that I know have a specialized cardiac genetic counselor involved, either embedded within a cardiology clinic or in a traditional medical genetics clinic. There may be a number of different rural outreach clinics as well that I don't have a complete list of, but suffice to say, if you see your city on this list, you do have access to a cardiac genetic counselor. So next audience question. So the patient that we presented at the beginning, what would you feel is the most appropriate genetic test to offer to the 16-year-old patient? Number 1, a targeted hypertrophic cardiomyopathy panel. Number 2, a so-called pan-cardiomyopathy panel, including genes associated with other types of cardiomyopathy, whole exome sequencing, or whole genome sequencing. Okay, so most of you chose a targeted hypertrophic cardiomyopathy panel. While it's not necessarily unreasonable to offer a pan-cardiomyopathy panel, I will discuss some limitations of arranging that kind of a test. Whole genome sequencing, we're not there yet, but that's something that might come down the pipeline in the next 5 to 10 years. So a targeted HCM panel is the correct response in this case. So particularly in the context of hypertrophic cardiomyopathy, arranging expanded so-called pan-cardiomyopathy panels tends to offer limited additional sensitivity. As you can see here, about 70% of cases of HCM are caused by mutations in 3 to 5 genes that are involved in coding the sarcomere. Also, doing genetic testing on genes that are not clearly associated with the phenotype of the patient is more likely to give you increased background noise, which I'm going to talk about more shortly. If you start looking into the various options for genetic testing, you'll find that there's a significant amount of variability in terms of genetic testing panels. So panels may be targeted to a specific phenotype, such as hypertrophic cardiomyopathy, or you may see expanded panels that include genes associated with various types of cardiomyopathies. The gene content can vary significantly from lab to lab, so you might find that an HCM panel may include only 5 genes, or it could include as many as 19 genes. The interpretation of genetic variants can vary significantly between laboratories, and as Melanie mentioned earlier, access to genetic testing can vary considerably based on geographical location. So you've arranged your genetic testing panel. What are the 3 possible results you might receive? First of all, you could get a positive result indicating that a pathogenic or a likely pathogenic gene variant has been identified. It can come back negative, no pathogenic variant has been identified, or you can get an inconclusive result where a variant of unknown clinical significance has been identified, where there is insufficient or conflicting evidence for the pathogenicity of this variant. So looking at our family that we presented initially, scenario number 1 is a pathogenic variant has been identified in the MYBPC3 gene. This confirms an underlying hereditary cause of HCM in this family. In this particular situation, this will not result in a change of medical management to the proband or the presenting patient in this family. However, identifying a pathogenic variant does facilitate offering cascade testing to family members, which allows accurate family risk assessment. So as you can see here, we've shown that the sister and the mother have tested negative for the mutation and now can be discharged from cardiology follow-up, whereas the father and cousin have tested positive and they now need intensive cardiology follow-up, typically annually. The test could come back negative. No pathogenic variants were identified. This does not exclude, first of all, a clinical diagnosis of hypertrophic cardiomyopathy, and a hereditary cause of cardiomyopathy has not been ruled out. As you can see in this table, genetic testing for pretty much all hereditary causes of cardiac disease, the sensitivity of genetic testing does not reach 100%. And for hypertrophic cardiomyopathy in particular, we're looking at a pickup rate of about 35 to 60%. So a negative result does not rule out hereditary cardiomyopathy, and at-risk family members require a comprehensive cardiac evaluation and ongoing cardiology follow-up. So in the family that we're discussing, who are the at-risk family members? In this case, it's the first-degree relatives of the index case, as well as the first-degree relatives of the individuals with sudden death. The third scenario, a variant of unknown clinical significance is identified in the MYBPC3 gene. This is an inconclusive result, and it should not influence clinical management of the index case or the family members. Surveillance of all potentially at-risk family members does need to continue, and ongoing interpretation of this gene variant is critical to assess the need for reclassification over time. So gene variant interpretation of pathogenicity falls on a spectrum ranging anywhere from benign to unknown to pathogenic. And there are a number of different factors that genetic counselors and laboratories use to determine whether a variant may be pathogenic. And a discussion of these different factors is beyond the scope of today's talk. Suffice to say that interpretation of genetic test results can and does change over time. And it is not unheard of for pathogenic variants to be reinterpreted as benign over time, which can have significant implications for family members, particularly those who have tested negative for the variant and have been discharged from cardiology follow-up. And this is a service that genetic counselors do offer, interpretation of genetic test results over time.
So to summarize what we've discussed in terms of approaching a new patient with cardiomyopathy, one would start out with a detailed 3-generation family history or pedigree. Also, a workup to rule out secondary causes of cardiomyopathy, which include metabolic and neuromuscular causes. And if those are found, then appropriate referral to specialists should be made. On the other hand, if it turns out to be a primary cardiomyopathy, then as we discussed, we would offer panel testing in conjunction with genetic counseling. For HCM, specifically, it would be panel testing. If a pathogenic mutation is identified, then offer cascade testing to the first-degree family members. But if no pathogenic mutation is identified, then continue with clinical screening of all first-degree relatives, typically every 3 years or so. What I also wanted to highlight was that the management of a cardiomyopathy patient is not just the management of the patient, but really management of the family, and does require a multidisciplinary team. And that includes not just a cardiologist who's well-versed in heart failure and cardiomyopathy, but an electrophysiologist to make the appropriate recommendations for an ICD if that's indicated, advanced imaging techniques, clinical geneticist, and a genetic counselor. And very important is that this is a rapidly evolving field, and genetics is beginning to play more and more of a role in the or we hope in the next few years will be playing more of a role in the management, not just of the family members, but of the patient themselves. There are emerging technologies, so wearable technologies is something offered to cardiomyopathy patients in general over the years, but there can be gene-targeted therapies. For example, myosin-targeted therapies are in clinical trials, phase 1 and 2 clinical trials for dilated and hypertrophic cardiomyopathy that may become relevant depending on whether you have a myosin mutation or not. There is also trials underway for offering preemptive therapy to individuals who are gene positive but phenotype negative to delay or defer the onset of a clinical phenotype. And in the future, gene editing or gene correction may actually offer a cure for cardiomyopathy. So it's important to keep abreast of these emerging therapies and give an option for patients to even participate in some of the trials. So the final thoughts, back to Josh.
So just a few things that we want you to remember from this talk. First of all, managing cardiomyopathy is about treating not just the patient, but the whole family. In terms of key points from genetic testing, it should almost always begin on an affected family member. It should not be performed in an unaffected family member unless a pathogenic or likely pathogenic variant is identified in the index case. Positive genetic test results may, but do not always impact medical management of the affected family member. Medical management is more likely to be impacted based on genetic test results in the case of the hereditary arrhythmias, which we didn't discuss in detail today. Negative and inconclusive results do not rule out a hereditary cause, and at-risk relatives still need ongoing cardiology follow-up. And interpretation of genetic test results is dynamic and can change over time. Finally, management of cardiomyopathy requires a multidisciplinary team approach. We've left you with a few references that are, we think, well worthwhile to read on this topic if you're interested.